I would like to dedicate this in memory of Francis Fessmeyer, a colleague, one filled with passion, love for his family, and I'm sure his spirit is with us today. So what I'm going to talk to you about is mission. And Will talked about vision, significantly taking out heart disease. Well, the mission of the society is to do that. And let's see where we are, how successful we've been, and where we're going. So we need to look at heart attack care in terms of where we've been, where we are right now, and where we're going. So the heart attack problem, as you know, is 800,000 deaths each year in the United States. We should be outraged that we allow this to take place. Let's take a look where we've been. Only 50-some years ago, mortality for heart attack was 30% when you were admitted to the hospital. Then we had CCUs and reduced it to 12%. And then we found a way to open the vessel after it had been closed with thrombolytic therapy, angioplasty, and we reduced it to 6%. And then we did something a little unusual. We did thrombolytic therapy in the field and we reduced it to 1%. 1%. In those patients, half those patients had ST elevation without enzyme change, showing for the first time acute prevention of a heart attack if you get it too early. Time is muscle. So the question is, and this was for STEMIs, this was for patients who are crashing, patients who had occluded vessels and the like. And the question is, at that study, the MIGHTY trial, Ward Kennedy, president of the American Heart Association at the time, said most important part about that 1% of giving thrombolytic therapy in the field was not the 1%, but was the fact that when hospitals were doing the study, they were randomized, and hospitals were doing the thrombolytic therapy either in the hospital or in the field. When hospitals were in the study, they did better than when they were out of the study. So all of a sudden, you came to the understanding that hospitals were not prepared. Hospitals in the United States were not fully prepared for patients with heart attack, the #1 killer of the adult population. So it raised the point, why weren't they prepared? Random care, if you went with a heart attack to an emergency room, you got random type care. So the question is, can we prepare hospitals? And that's how chest pain centers got started. Why not? Let's bring together the cardiologist and the ER physician. It was tough initially, but they came together and they put together a plan, best practices, and seemed to work on it. And chest pain centers became a way of preparing hospitals in their emergency rooms for patients coming in with heart attacks. We continue with that at our hospital, and then the group that was meeting with us, ER physicians and cardiologists and critical care nurses, decided that, why don't we form a society? Just think about it. That's unheard of. Form a new society. You had cardiologists and ER physicians, ACEP, but this would be a bridge society. That in itself, if you think about it, is momentous. This group put together the Society of Chest Pain Centers and Providers in order to do best practices to prepare the nation for taking care of patients with heart attacks. Later on, because of an issue with the HCFA or CMS now, they asked us to do a sort of accreditations to accredit the hospitals that they were doing best practices and the like. Accreditation has done a lot of great things because it prepares the hospital not just for chest pain, but for other things as well. It really makes the hospital much better and the like. And already we've changed some chest pain centers to cardiovascular patient care because we've embraced other issues, heart failure, atrial fibrillation, and what we're doing right now in terms of that. But still the mission of society was to significantly reduce heart attack deaths in the United States. And what really helped us was we discovered that half the heart attacks had beginnings. Half the heart attacks had beginnings. Beginnings were in the community. Will just talked about that's where the problem is. We tried to get to them earlier. But half the heart attacks had beginnings and they were stuttering, things like that. So was that mission impossible? How were we going to get to the patients with these early heart attacks? So our mission was to reduce significant heart attack deaths, but we got 800,000 deaths, and if 50% have beginnings and are stuttering type MIs and are occurring in the community, that's where the greatest impact is. So if we can move in that direction and reduce it by 400,000 or something like that, or in that direction, then we'll be moving in terms of significantly reducing heart attack deaths in the United States. So in order to do that, what we had to do was we had to prepare 5,000 hospitals and with chest pain centers and 310 million Americans and change the culture in terms of heart attack care. Mission impossible? Yes, but mission possible with small successes along the way. So this level EHAC, I know it stands for early heart attack care, but what we're talking about is acute prevention of a heart attack. It is true that EHAC is the education, but we're really talking about acute prevention of a heart attack. The reason why it's twice the size is because more is done when you give therapy early. So we're introducing this new link. Now, people might say, well, we've had this before. We know early care, but you don't know really early care until you effectively put into place ways of carrying it out. And that's what we were about in terms of chest pain centers. So we're trying to deliver this level of early heart attack care and take it to 5,000 hospitals and to all of America. How best to do that? Well, the two badges that you will see around here are good ways of explaining what we're about. Now let's take a look at this badge. Deputy heart attack badge. It's a deputy. Why? Because deputy, you recognize that there's a national crisis. The sheriff in the old days, national crisis. You deputize everybody in town. Heart attacks at beginnings. You're teaching a person who comes upon you that not just a deputy, but your heart attacks at beginnings. You want them to ask you so you can educate them. So this is a way in which you can individually get across the message and be a factor in terms of implementing this. And then when you take that pledge, you pledge to stop what you're doing when you hear somebody with early symptoms and stay with that person until they get help. It's like the old E.F. Hutton commercial. You know, someone said E.F. Hutton and 15 people are talking, and they go back and they listen. When someone in your midst is having this off and on discomfort and they're sitting down and they said they're going to be all right, you know there's a lot of denial and there's A lot of 80% of people that see this become enablers. You're okay, just sit down for a few minutes, I'll see you later. That's got to change. So when you take this badge and take this pledge, it means that you're going to be part of the solution to the problem of heart attacks. The other one is also very important because this is saying here that even though the patient has denial, you're a good buddy, good Samaritan. You're going to help that person, and you're not going to leave that person until you get them into the hospital. And the hospital has also got to be user-friendly, and that's what we have in terms of observation services. It used to be GOMER mentality, acronym for get out of my emergency room unless you got severe chest pain. We now changed it to Tuffy. Thank you for coming in early. And that's what we need to do. And that will encourage more people to come in early. It's a user-friendly emergency room when you're coming in early. As Will said, you want to get that person early because you want to see a person walk out with his life, his muscle vessel, and saying, what can I do not to come back? And then you educating one on primary risk factors, prevention, and the like. So the society has done a lot of great things in terms of moving in other directions and like, but the vision and the mission is still the same, to take heart disease out of first place by a united approach. And one of the things they did recently was we had key elements for maintaining a chest pain center accredited. We say, well, you know, if our mission is to take heart disease out of the first place, then EHAC needs to be first. And we made EHAC key element number one. Not only that, but we went to newly accredited hospitals and said, now you got to teach EHAC to all your employees, all 3,000, 4,000, 5,000 employees. Required now. You would think that they would be a little bit upset or something like that. No, before we would create chest pain centers, but we didn't tell them what to do. But now we're saying, can you do this? And they overwhelmingly said, yes. They're teaching newly accredited hospitals, all their employees. We have a website for EHAC. We have a standardized EHAC course. And not only do we require it, EHAC be taught, but we're now giving it to the hospitals so they can put it on their advanced learning system, HealthStream or whatever they have, in terms of the fact that once they put it up there, then the employees have to take it on a yearly type basis as part of their employment. So what has this done? This is just trying to show the power of an idea whose time has come. This has been repeated along the way. Coronary care units. A general practitioner in Bethany, Kansas, said when you had information on CPR, why not put patients with heart attack in one area of the hospital? And the first coronary care unit was in a community hospital. Within 5 years, every hospital in the United States had a coronary care unit. The power of an idea whose time has come is important because it's actually makes sense and people want to move in that direction. Well, same thing with chest pain centers. When I was at St. Agnes, we had 2,000 chest pain centers, but they were not accredited. They did what they wanted. Once we formed the society, then we moved toward accreditations. But now we've taken the accreditations and moved to a more aggressive EHAC, teaching acute prevention. And within the last 12 months, we've had 195,000 people go to our site. We have a counter on our site that when you come on and take the course, we count it. 195,000 have come on within the last 12 months. This is the power of an idea whose time has come because of the fact people want to know this information. Now, we're going to accredit somewhere between 250 to 300 hospitals before the end of the year. Well, you do the math. 5,000 employees, 300 new chest pain centers, you're going to have over 1 million people coming on board. Now, what does this mean? This means that you got an army of people in the community who are looking to spot a person who's having early symptoms in order to get them into the hospital. They're prepared. It becomes a more safe community because there's people interested when you have these symptoms. The important aspect, you need to convert the enablers to caregivers, and slowly we can move in that direction, because that will then produce a community that's safe. Because we're going to grow chest pain centers, but the future has community heart attack care or the community coronary care unit. As Brownwall has said, the ultimate coronary care unit is in the community. And what we're doing is moving to a virtual coronary care unit or heart attack care unit, or we call a safe community in terms of safe in terms of early symptoms, safe in terms, right now, I don't know if you know, but there are 600 heart-safe communities, and these identify themselves by survival for cardiac arrest and with AEDs. And there are signs up when you go into these communities. We are working to partner with these 600 in terms of adding the EHAC component to it so it becomes safe not only in terms of a cardiac arrest, but also getting the person early to prevent the acute heart attack from occurring. And then part of the observation area in which only about 15% do have true ischemia, 80% go home, but they have a little higher risk factors. It's a teachable moment, and we're able to couple EHAC, acute prevention, with the primary risk factor prevention as well. And they're more apt to learn in this teachable moment. So we're working towards making these safe communities. Now, I think what we're doing is we're jump-starting this process, because EHAC is not going to be just with chest pain centers in the future. This is really a public service message. We already have chains, hospital systems that may have 15 hospitals of their 70 hospitals with chest pain centers, but they want to teach it to all their employees. Why not? This is a public service message. And chest pain centers, as Will pointed out, are trying to make it better, but we can't do the job all ourselves. It depends on the community getting more involved. So the ultimate coronary care unit is a community coronary care unit. So with that in mind, we're going to have you stand and take the oath and pledge that you will be an early cardiac caregiver. So let me see you all stand. And since this is a meaningful message, I really want to hear you commit yourself to doing this. I solemnly swear that if I am in the presence of someone with early symptoms of a heart attack, I will stop what I'm doing and take that person to the nearest hospital. Okay. We have more information at our booth. We have, and I'll see you later. Thank you very much.